Everyone to the Certifying Ambulance Transports webinar. We will focus on what ambulance suppliers and professionals need to know about certifying the ambulance transport's medical necessity. I'm Tom Ryan from Provider Outreach Education. I'll be your presenter today. I'm joined by Jennifer from my team, who can help with any of those, interesting medical problems or medical questions that you may have if you want to know more about that. Jennifer is one of our registered nurses. She's also going to monitor questions in the chat, help you out there, and maybe put some reminders and other things you might want to know. I do want to remind you that there is a disclaimer at the end of this presentation, and we would recommend that you take a look at that disclaimer. In this case, just know the information was current and relevant, again, as of this morning, but that doesn't mean it couldn't change tomorrow. All right. What are we here for? We are here to identify when Medicare needs a physician certification and the physician certification components. The physician certification statement, or PCS, is what we will refer to throughout this program. Okay. The first thing, we're going to have to define it. Now, I will tell you that I did have some people who are fairly new who did register. This is a very commonplace. So we built some slides and wanted to make sure we hit all of their information. We then will talk about the usage of the physician certification statement, or PCS, and we'll talk about the mandatory elements. One last thing before I leave my agenda slide. This information is relevant across the board for national information when I'm stating that there is national information out there. There is information in here, such as the sample form, that is for WPS providers only. This is in Jurisdiction 5, Iowa, Kansas, Missouri, Nebraska, and other states that bill on the UB04 or 837I who are registered as part of Jurisdiction 5. It's also for Jurisdiction 8, Indiana and Michigan providers. So while we did have a lot of other states register, we want to make sure that you are aware of where this information comes from. Examples of other states: Texas, Arizona, Pennsylvania, Nevada. Those are all other states saying, hey, I bill in a 1500 claim form. Again, you're welcome to listen and we'll get you the information we need, but our questions are going to be aimed at our providers, which are in Jurisdiction 5 and 8. So the first thing I like to do is start with that basic building block. And that basic building block is to define the physician certification statement and ambulance medical necessity. Some people did ask if you could need a physician certification statement outside of the ambulance medical necessity, and I wasn't really sure what that question was referencing, so I'll put that out there right now. Physician certification statement is for medically necessary ambulance transports that require them. Not all transports will require them. So we're going to talk a little bit more about that in just a few moments. Okay? But first, let's start off defining medical necessity. So what we do when we talk about medical necessity, specifically for an ambulance transport, okay, specifically for an ambulance transport, we start with the Social Security Act and we look at Section 1861 S7. During that section of the Social Security Act, and I'll show it to you in just a moment, you will see the words contraindicated and ambulance service or transport service. Okay, that means that it has to be a transport. If you don't transport the patient, Medicare will not pay. Also, contraindicated is defined as the only safe means of transport. So in order to meet the medical necessity requirements, it has to be a transport, but the ambulance is provided, can't be a treat, no transport, and it has to be something that is the only safe means. So if someone could go in a wheelchair van, that is not going to meet a medical necessity requirement. Okay? Then we look further into it and we look at Section 1862 A1A, and what we're looking for is the medical necessity. Okay, what does that mean? Well, so we talked about the fact that it's only payable if it is the only safe means and a transport occurred. Then when we look at the 1862 and the medically necessary says, what is the level of care required by the patient? That's what we're looking for here. So when we look at an ambulance, if they could have gone by basic life support ground, we're not going to pay for anything else. We're going to pay for that BLS service. Now, if they could have gone by maybe ground, but they went by air, that's again what we're looking for when we talk about medical necessity. Okay. So sometimes the physician certification statement will tell you, hey, I need them to go by air for dot 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 reason. That's okay. That's what we're looking for, right? So um, then if it meets all of the requirements, that's my favorite part of 1862. It says it's got to meet all these other requirements. So what does it have to meet? Things like Medicare secondary payer, things like the billing requirements. It has to be billed properly. Without those basic requirements, it also will not be payable. So what I wanted to show you, or what I wanted to just really quickly run through, is these two links right here, and they are both linked on the slides. So if you do have the slides open, you don't have to try to remember this. You can simply select section 1861. And the reason that I'm showing this is because someone said that one time when I had referenced this on the previews that they could not see it. So they asked if I would help them again here. So here's where you get 1861. Okay, so we know we're in 1861. We know that we're in A. That's where we start. Now, if we scroll down, you'll see B, C, D, E, and keeping going through E, you'll come to F, G, H, and again, this is just me scrolling through. Now, the reason that I'm doing this again is because the people had asked for help and they really were looking for how to read this. So we're scrolling down, scrolling down. Okay, then you're going to come to medical and other health services. This is where you're going to hit S, medical and other health. Now you're going to start looking for one, two, again, scrolling down, and you're going to find seven. Okay, ambulance service where the use of other methods of transportation is contraindicated. So it has to be a transportation service and it has to be contraindicated, but only to the extent provided in regulations. That's that other part. Now you can do the same thing if you want an easy access. You can jump back and sort all the way through this, or if you're back on my slide deck, you can simply select 1862 and then A1A is super easy. A, notwithstanding any other provision of this title, 1A, which accepts. Okay, and then it talks about the medical necessity for it. So, and here you'll see it says are not reasonable and necessary for the diagnosis or treatment. So when we look at it, that's where we come up with the full definition for what medical necessity is. Okay, it has to be a transport, has to be at the level of care needed by the patient, okay, and in order to be covered, period. Okay. All right. So next we're going to move on, and we're going to move on to slide number 5. This starts the basics of the physician certification statement, or PCS. A few of you referred to them as ambulance orders. That's fine too. The official technology, or the official terminology from CMS, is PCS, or physician certification statement. So, a couple of things to keep in mind. A physician certification statement is a way for medical professionals to provide information about why they believe the ambulance transport is medically necessary and covered. So the physician certification statement, if Medicare is not covering it, you don't need one. Okay, we're not looking at that at all. What we're looking for is what does the physician feel, and I'm using the term physician relatively generically right now, and we'll get more into that in just a second, and I'll come back to that. But what does the physician or medical professional feel that this transport should be covered today? Okay, the information is helpful for the EMT during the assessment, but it does not determine medical necessity alone. It is helpful for the emergency medical technician. Doesn't matter if it's a basic, intermediate, paramedic level, whatever level, it's helpful to them. It does not establish medical necessity. The assessment is the only thing that does that. Okay? When you're looking at this, there are certain criterias. One of the things that it says that in the Code of Federal Regulation, which is down here in the bottom, right here, is that it can be signed before the transport occurs, but not more than 60 days before the transport occurs. So the physician certification statement is a statement written by a medical professional explaining why they feel the only safe method of transport for this patient for a service coming up is an ambulance. Then the EMT takes that, they may look at the patient, and they say yes or no. Okay, yep, but we agree or no, we don't. The patient's moving around just fine. But it's why the professional feels. Okay. Inside this Code of Federal Regulations down here, there are different statements that are made. And one of the statements that I think is important is to understand that it allows for doctors' signatures and non-physician practitioners such as PAs and other certain things, and we'll get more into those in a little while. But if it allows for that, then how do we know? Which is our next slide. So what we're looking for is the attending MD or DO to sign a statement for a routine scheduled transport. We'll talk more about that in just a little while. Remember, those statements cannot be signed more than 60 days before the transport. The person is the direct care of the patient. So whether they're the primary caregiver or whether they are a specialist providing the care, that's fine, right? So there may be primary care for end-stage renal disease, but they may not be their overall primary care manager. They may not be their overall primary care doctor. And either one could sign if it was for end-stage renal disease. That's why managing the condition is so important. But one thing to keep in mind is we really do want you to note that they do have to know the patient. Someone had put in a question and they said one of our staff members signed for them from the skilled nursing facility. Okay, first, there's a lot of other questions that would go with that, like do they actually know the patient? Are they part of the patient's care? There's a variety of other things. But then, do they meet this requirement, which is the non-physician certification, okay, or NPP signatures? So within the Code of Federal Regulations, it does tell us that for a routine scheduled transport, it must be a doctor. Now, a doctor can sign for any of them. That's why it's called a physician certification statement. Then within that Code of Federal Regulation, again, it's down there on the bottom, you can see 42 CFR 410.40E3. There's also something called a non-physician certification statement. During this course, I'll simply refer to it as a physician certification statement. This then allows certain non-physicians to sign in certain circumstances. They can sign for something that is unscheduled or a one-time transport, and we'll talk more about that in just a little bit. One time is fairly clear, right? It's only going to happen once, but unscheduled, what does that mean? And that'll be our next point of view. So which non-physician practitioners who have direct patient knowledge can sign? A nurse can sign, a physician's assistant, a nurse practitioner, a social worker, a case manager, or a discharge planner. Keep in mind, we would ask that you put the credentialing with that person's name, just like with an MD or a DO. We always ask that you include that information. It helps us to make sure that we're meeting the proper criteria, things like that. Now, we want to make sure that everything is available for you. So then it goes on and we find out, oh, well, you said it has to be a one-time transport. We got that, but or an unscheduled. So what is considered an unscheduled transport? So one-time transport can occur to a facility for an evaluation, for a test. An example, someone needs an MRI. That's a one-time transport. We aren't anticipating them going back for multiple MRIs. That could be set up in advance of the day of service. A scheduled transport, though, does have a very defined meaning. It is set up before the transport. We do understand that. It has 24 hours or more in advance. This is a known transport. Now, someone said it's set up the day before. Is that the same? Great question. And the answer is technically no, it's not 24 hours in advance, but if that's your definition, that's fine. So you want to make sure that it's scheduled. Okay. So that means that if you know it's coming and it's scheduled, but it's only going to happen once, one time, or it happens where it's not scheduled, you didn't schedule it out, but it's going to occur in 3 hours, that would be an unscheduled transport, then you could follow the non-physician practitioner signature rules. Okay. I will remind you that a routine scheduled transport, that a scheduled transport, routine scheduled transport must be signed by an MD or DO, and we're going to get a little bit more into that. Okay. Then we get into usage. So let's stop for 1 minute here and see if we have any questions in the chat, see if we missed anything or anything else someone would like clarification on. Jennifer, anything in the chat?
We got one question just asking, is a PCS form required to bill a transport to Medicare for medically unnecessary transport in order to receive a denial?
Oh, no, unnecessary being key there. So for those of you that missed that, this person saying this is not going to meet the definition. This is not part of the Medicare benefit package. Unnecessary. No, no PCS required. The denial should come without the PCS, but could require a modifier, GY, GA, something like that. So anything else?
That's all.
Okay. So next we're going to talk about, remember, the physician certification statement. So what we're going to do is, when do we know who can sign which ones and which ones are a little bit easier? And I want to give some more clarification to that. So first, the physician's signature must be on, and again, we're talking the attending physician, for the routine scheduled non-emergent ambulance transport. These are scheduled 24 hours or more in advance. Now, we do say more in advance because remember, you can have 60 days in advance. That's fine. And then you can actually apply for a prior authorization before that process. So there's a variety of things that you want to keep in mind. So how does CMS define a routine scheduled ambulance transport? Again, this occurs more than one time and you know it. You know it. I'll give you a couple of examples. Dialysis transports. The person's going to go for dialysis 3 times a week. You know they're going to go for 3 times a week. Okay, then you can apply or you can get a physician certification statement that is signed by an MD or DO. Another one could be some of the cancer treatments, just depending on what they're having done. Okay, so really we know this is going to happen. I want to make sure that everyone is aware that this is not for an emergency service. Someone called and said, hey, it was dispatched through 911. Does that make it an emergency service? Nope. That's not the emergency service portion. In some areas, 911 is the only dispatcher. So just because it's dispatched through 911 does not make it an emergency service. It could be an emergency service, and we don't want to take that away either. But we're saying, hey, if we call and the only place we have to dispatch these is through 911, and they say, hey, but by the way, the patient doesn't need to be transported, or the patient needs a transport, it could be a one time, or it could be falling under these physician requirements. Okay, just depends on how far in advance. And the transport must occur within 60 days of the signatures, which means the physician signature. Again, if it gets outside of 60 days, it will not be considered valid for Medicare. That is in the Code of Federal Regulations. On the other hand, there are again those non-physician signatures. So they are under the care of a physician is very important for this one. Um, if they're not under the care of a physician, then this is not an applicable. This does not mean that they are at a physician's office or a facility. They could be at home, right? They could be at home, but they're not under the care of a physician. So if you think about the MRI example, and I know I originally said skilled nursing facility, but let's change that. The patient needs to go and is bedbound and needs to go to an MRI, needs to have an MRI. Whatever the condition is, they need to have it. This person is under the care of a physician. They didn't just decide one day to have an MRI, even though it might be scheduled, right? It doesn't mean that it's that way. They are unable to attain the attending physician's signature. So you went to their home to take them to their MRI. Is the attending physician there? No. So could you have someone else involved? Sure, you could. And there's a whole set of requirements for those. Now, typically they're coming from a nursing facility or another type of facility where there would be someone like the RN available to do it. Now, again, these physician signatures are not used for RASNet. That's a prior authorization decision. So the routine scheduled non-emergent ambulance transport requires a prior authorization. But again, these types of signatures on a physician certification statement or a non-physician certification statement will automatically make it invalid for the RASNet program. Now, I don't want you to take that and say, Tom said it's invalid always. No, for the RASNet, for that prior authorization process or program, it will make it invalid. No physician or NPP signs for one-time or unscheduled transport. So I want you to notice again, here we're saying, hey, we don't have a signature. What do we do? First, if it is a routine scheduled non-emergent ambulance transport, you have to have a physician certification statement. Without it, the transport is not payable. If not, then you can go back to the physician after the transport. So example, the MRI from home, and you can say, hey, I need this signed, and they could give you a signature after the transport. Perfectly fine. Um, Multiple tries, you want to send it, you can send it via email, send them whatever you want to do there, but you want to try to get that. If at 21 calendar days past the transport date you did not get a signature, this is fine as long as you've documented that. We tried multiple times to get this signature. Then you can actually submit without the physician certification statement. Now, I do want to remind you that there are other ways you can get around that, but the biggest concern coming from this slide is the people that are saying, hey, I picked him up at home for an MRI, or I picked him up at home for a procedure. They're going to come back home, but they can't go on their own, and we don't have a nurse. We don't have someone available right there to sign for this. What do we do? That's when this no signature rule comes into play most commonly. Okay? We were asked very specifically, when is a PCS required and when isn't? Well, PCS is not required when they're not under the care of a physician. So if a person falls at their home and they don't have a physician who they're seeing for this related condition, they're not under the care of a physician. Yeah, I understand you're taking them to the physician, you're taking them to the ER who's going to see a physician, possibly, or an NPP. I get that, but they're not under the care of the physician for this condition. If it is an emergent transport, no PCS is ever required. It's an emergency, get them there as quickly as you can. Also, and this is going to answer the question that we were asked, it is a non-covered transport. So it does not meet the definition. It's not the only safe means of transport, they weren't transported at all, then that portion is considered non-covered and would not need a PCS. All right. The next section is going to be the elements. So I do want to take just a quick moment here and see if we have any other questions that came in.
We do have one question. Okay, I'm going to say it slowly. If the patient is being discharged from the hospital or SNF or another hospital, is the signature date the 24-hour plus rule? Sometimes the discharge date gets pushed out by a day or two, so they're not really sure if they need that updated signature date.
Great question. The signature date falls into the one time because I'm assuming if you're discharging them, you're not anticipating multiple. Now, again, that could not be true if you're discharging and you're going to a home and then you know they're going to have dialysis and they're going to come multiple times. That would be a different situation. But the actual discharge transport would be a one-time transport. So, a couple of things. One, if the physician has signed it, yes, you could follow that 60-day rule. Understand it's not within the 24-hour rule, but why do they still need that transport? As a matter of fact, there are times when the patient can actually fight the physician. I don't know, that's not the correct word. The patient can disagree, I guess is a better way of saying it. And they have an appeals process they can use, which would delay the discharge during the time that that takes place. And that's usually 24 to 48 hours. It's not that you need a new physician certification statement. It's that, hey, this is for the transport. We do feel it's medically necessary for them to either go home, to go to a skilled nursing facility, to go to a hospital. What's going on there? So that's what you're looking for. So it could be, again, 60 days in advance. Yes, we understand that. It could also be that you're having one signed that needs to be for like a dialysis treatment, but then a different one signed for maybe a different level of care, like to a skilled nursing facility. So I don't really have a great answer. I'm not sure what you're talking about. In terms of the facility to facility, though, yes, a physician could sign it. Yes, it would still work for them. They just need to put that it's for the transport to another facility and why they feel it's medically necessary, and then sign and date that one. And it could be a day or two later. We understand this does happen, that the patients do have the rights and stuff like that. So anything else, Jennifer?
No, that's the only question.
Okay. This is the biggest part that I received the most questions on. Thanks to those of you that did. To those of you that are new, you had some interesting questions and you interested the way that you asked them. I'm hoping I'm going to meet all of them. But this is the elements of what needs to be in a PCS. Okay. So each PCS must have some basic information. There's also some types of information that will make it stand alone. The key thing that goes with this when you first get started is that each ambulance supplier must decide what works for them. This is not a CMS required form. There is no CMS required form. However, the Code of Federal Regulations does state that. So we're going to get through some of the elements and then we'll answer some questions, okay? Basic, what needs to be on the PCS? What information is required, or is there a specific format? We already answered the format. There's no specific format. What information needs to be required? We'll talk about that. And again, what topics or what information needs to be there? We'll talk more about that as we get through these requirements. The first required element, and at this point, I may ask Jennifer a couple of different times to chime in. She's our clinician, so that's what, she'll have more expertise if I'm missing something here, but is the patient's information. This is what identifies the patient. So the name must match the Medicare record. Now, if you say, hey, I can kind of match it, or it's a commonly known name, that's fine. But you may need to make a note inside the actual medical record that you have, not necessarily on the run sheet, but in the medical record somewhere, telling us, hey, we understand that the medical record says for Susan K. Smith, but they go for Catherine Smith, and Susan is not used within this patient's name. So therefore, okay, that's a way of explaining to us why the PCS doesn't necessarily meet anything. We also do recommend a date of birth, sex code, and Medicare number. These are the basic elements that tie the patient within the Medicare system, which is why we use them. Um, if a couple of these elements are wrong, can we actually use that PCS? As long as you've documented that they're different or what you found to be wrong, we can get away with that, and we want to make sure that you document it. Hey, the physician filled this out, but they didn't give us the right date of birth. They put 1963 and it should have been 1964. Something like that. So I want to stop here for just a moment and see if Jennifer has any advice from the coding of the patient's information, for making sure that the record has it so that you get it coded correctly on all of that. Jennifer, anything to give?
No, I mean, exactly what you said, making sure that it matches, definitely making sure that the name of the Medicare record and the date of birth do match. That is something that we see that comes up. Um, just making sure that you verify with the patient that information.
Okay, thank you. Next comes, oh, well, next comes the medical professional. Now, a lot of people ask us about this particular piece of information because they say, well, the medical professional, who is that? Well, I already gave you a list. It can be the doctor, it can be a non-physician practitioner, but this would also include an EMT signature, emergency medical technician at whatever level. Again, remember, CMS defines it basic, intermediate, and paramedic. If your state says a paramedic's not an EMT, they're a separate category, that's okay. We're going to use the CMS definition this time. So, what do we know about a signature from a medical professional? It has to be legible. Okay, yeah, I'm just going to stick my tongue in cheek on that one because a lot of those signatures are not legible, and that's also okay, and I'll explain that in just a moment. So, it does have to be dated and it does have to contain their medical credentials. The reason for that is we need to know what level they're at. So, for instance, is it an EMTB or an EMTP, paramedic, versus a basic EMT? Is it a doctor or is it a non-physician practitioner? So we want to make sure we have all of those medical credentials just in place for us. I will tell you that I did put complying with Medicare signature requirements. This is about the professional signatures, not about the patient signatures, which is why I thought it was important. A couple of key things I want to talk about with this. If you have I'll call it a squiggly mark or an X, or I don't know, the medical professional signature is not legible. Are there things you can do? Well, in real life, yeah, we know this happens. So, could you provide a handwritten signature with the typed information below it? Yeah, that's acceptable. Could you provide an attestation statement or signature log so that we can see that that squiggly or that whatever that is relates to this? Sure, why not? What you can also do is have them electronically sign it. You may have a shared medical record or a way to get that back and forth, and that's great. When you have those, electronic signatures are fully acceptable. The one that CMS does talk about still is a stamped signature. We don't see these very often, but there's just very limited use with them. So if you want to learn more about stamp signatures and when that would be acceptable, I do recommend that you take a look at this complying with Medicare signature information and kind of get through some of that stuff. It's a Medicare Learning Network fact sheet, and again, it is linked right here on the bottom of the slide. We still do have to have some basic trip information. When we talk about what needs to be on the physician certification statement, we need to know a little bit about that trip. What's the date of transport? Or is it multiple dates? So for instance, they're going for end-stage renal disease transports, and here's the time frame. Okay, well, they're going to go 3 times a week. Okay, that's what we're looking for. What is the different means of transport that is unsafe? Why is it unsafe? And it may not be anything. You may not necessarily need all of these answers, these questions answered in some cases. But like the patient maybe has an ulcer or a bed sore or something like that and can't sit for the time of transport to the end-stage renal disease facility. They have to be adjusted and rotated, but they also are not currently able to get out of bed, so they're bedbound. Okay, well, all of that's great stuff. We don't necessarily need to just say, hey, it's unsafe for them to go in a wheelchair van because they can't sit in a wheelchair right now, right? You're going to tell us about that. What needs the monitoring? This is a great one because we get things like they have oxygen. Okay. Do people live with oxygen every day? Do people walk around with oxygen tanks every day? So what does that mean? Why are you monitoring that oxygen? What are we looking for with that monitoring that's going on? And then are the basic requirements met? Is a transport occurring? Is it medically necessary? If not, then you don't follow that. And also, is it at the level needed? Could they have safely gone by ground? On which level of ground? Those are the basic requirements that we should look for within the trip information. I'm going to bring this one up and then I'm going to switch for a second here. I'm going to go to the website for y'all. Okay, so the website that we're going to go to this time is the WPS GHA website. It's WPSGHA.com, and we're going to talk about a sample form. Now, the sample form is something that was developed by our team to help you. Now, it's one of our registered nurses and one of our clinical medical review nurses that developed it together. Our being the outreach nurse and the medical review nurse. So what do you want to look for? I always tell everyone you can do it a couple of ways, but tools is one way and topic center. I'll just go to tools. When I look for tools, I'm just going to scroll down to the all tools. Then I'm going to scroll and you can see the third item in the left column is all forms. Now, if you don't have this the same size I do, so you don't have, as many boxes or whatever, you're just going to want to find the all forms. Then you can kind of go through, and if you know what you're looking for, right, you can scroll through and find it there. I always like to do this because then I don't have to try. What I did is just use my filter feature. There it is. Here's my sample form. It's going to explain a little bit about it. And again, remember, this is not mandated. This is a sample form. We're going to open it up. What happens is it gives us all of the basic information to make it super easy to find the patient. So that's the first problem that we sometimes have. Here's the start dates and the end dates. Again, if applicable. Why does it say if applicable? Well, what if it's a one-time transport? So it has a start date, but there's no, it could be the same. Physician's name, NPI, and then origin destination. And you can see through all of the basic information. This just helps us a little further. This is the part that you want to make sure has something in it, and that it is more than just they need to be transported or they're bedbound. Those statements alone don't help us. Okay, so requiring the ambulance transport, they're going for dialysis and are bedbound. Okay, the patient is bedbound, yes, but then no, they need to change. What do they need to do this? For the transport. They can't sit. Are there special handling instructions? And a lot of people say this has got a lot of information on it, and we do understand that. We get where you're coming from. The reason that this is designed is for one, routine scheduled non-emergent ambulance transports, two, for anyone else using it, which is why at the bottom it does say, hey, who is this? Right? And then it gives us the little statement about the non-physician practitioners who can sign. So hopefully that kind of helps everyone. But again, I want to make this clear. This is not a mandated. You can make your form look like however you want, as long as you have the appropriate information. All right, jumping back to my slides real quick. So summary. Scheduled ambulance transports, do they need a physician certification statement? Yes. And it actually does need to be the doctor or, I'm sorry, the medical doctor or the DO that needs to sign. They cannot be more than 60 days before the transport. So the date on that form, on the bottom, it has to be dated and it cannot be more than 60 days. Okay. They can be recertifying every 60 days, which means you could get a new one every 60 days. And that also happens, especially with some of the, the cancers, the kidney dialysis, all of those types of things. We then move to the non-scheduled or non-repetitive transports. And I want you to notice non-scheduled was what? Under 24 hours. Non-repetitive means it's only going to occur once. It doesn't matter that it's a week out or 2 weeks out. It's only going to occur one time. My example there was that MRI one. Okay, so then yes, we offer a variety of people that can sign, and that's listed for you here, but they do have to have knowledge of the patient's condition. They do need to be employed by the attending physician or a transporting facility. Attending physician or a transporting facility. So when we look at those, that's what we're really looking for with the physician certification statement. What I'd like to do next is actually just go through a couple of different physician certification statements. So there's going to be just, some samples for you guys to take a look at. All right. On example one, this is the identifying information. So you can see they did use ours, and everything that has a blue box, it's just redacted. It's not anything that wasn't missing. If it was missing, it would state so, or it wouldn't even have a box because we wouldn't have to redact it. So do we have everything we need? Okay, well, we have the patient's name, the date of birth, the Medicare number. We know that it's a female. We know that they were born on January 6th, 1926. Here's the physician's name and NPI. They were picked up at a residence, and here's the address, and here's the destination. They need to go 3 times a week, Monday, Wednesday, and Friday. Okay, awesome. So we have everything we need on the basic top part. There's nothing more we really need to know about the identifying of the patient. By the way, she's going to a wound care center, and this is what the 3 day a week is. She's going to a wound care center. She has a wound vac on that needs to be changed, so that's why she's going. So then we get down into all of this stuff, and we're like, whoa, okay, here we go, right? This is going to be a little bit more. This is the medical necessity section. So this does tell us, okay, patient is morbidly obese. She is unable to bear any weight on her own. Okay, she's got extreme lower weakness due to prior medical issues and non-weight bearing. Unable to tolerate seated position due to location of wound and patient weight. So she's got to go by ambulance because she can't sit and tolerate it. Wound vac must be changed 3 times a week. Okay, so are they bed confined? Yep, they gave us a little bit about that. What do we know? Well, unable to sit, to hold self, and be seatbelted. Yep, there's a contracture, and then here's why. Special handling instructions. Okay, got all of that. They also need to monitor oxygen. Also need to monitor oxygen. And then repositioning of patient due to location of wound and size of patient. So there's a lot of information given within this one that actually really explains very well what we need. So on this one, is it a good example? What do you guys think? Yes, yes it is. We've got our signatures. You can see this is an MD signature. Here's the date. So this one's good. We know this patient's going to go 3 times a week. This is a routine scheduled ambulance transport. It must be signed by an MD or DO. Is it? You bet. Does it have all the information to explain what we really needed to know about it? It does. This is a good example, which I just talked through here. So I apologize for that. I didn't advance my slide. So we have everything we need. We're going to move on. On example 2, now here you can see it's going to look a little different. Again, it's just a different type of form, right? But we do have the patient's name, date of birth. We're going from home to dialysis. dialysis and back home. So ASAP, uh, patient's Medicare number is there Tuesday, Thursday, and Saturday, 3 days a week, 10 a.m. Gives all the different information you need. So can you identify the patient? The answer is yes. Do we have what we need there? Great. We do have what we need. Now, this is one, and I just want to remind you that this was sent for the repetitive scheduled non-emergent ambulance transport. Whoop, didn't mean to advance beyond that one. The medical necessity context contains information the patient's unable to walk and needs help with most everything. But I want you to note that that's what they say. Needs assistance with everyday life. Okay, they're unable to walk or transfer, needs help with most everything. Well, does this mean that they couldn't stand and pivot? Could they stand and pivot, get into a chair? So just because they can't walk, there's a difference of ability here. And this is where we wind up with some of the hardest parts of this, because there's not enough information to really get us down into what we need. Okay, and then yes, this is the closest facility. So this is very vague statement. This just gets through and talks about all of it. This is a different way of giving us the credential. So you can see here's the name with the credential. Then they signed it below it, the date, and the physician and NPI. So this is another way of giving us that, but not wrong. We want to make sure you guys are very aware of that. It's not wrong. Okay. So this one then goes through and we stop and we say, let's go back. And what happened here? Well, the reason's too vague. We're missing details. We don't really know what's happening with this patient. They need help with everyday assistance, but what does that mean to prove that it's medically necessary for an ambulance transport? So this one was denied, and again, this was submitted for the RASNet, the Routine Scheduled Ambulance Transport Program, and this is for a prior authorization to say it's medically necessary, and we just don't have that from what was submitted. Example 3. Again, identifying information. What's missing? There isn't much missing. That's what these two boxes show. But instead of being spelled out in exactly, or I'm sorry, these two boxes show the provider information, the patient's information is these ones. But again, date of birth, we've got all the information we need, right? We're good. So that part of it isn't the problem, and that's not normally too bad. On the next slide, do we have something that says, hey, what's going on with this patient? Well, first of all, I want to note, and I will say in this case you can see, but notice the skew on this. Sometimes we get them and they're actually skewed enough that we can't see what's being checked up here or if one of these other ones is checked. So like 11, 12 might be cut off, starting to get down into this. That doesn't work either, especially if something is checked there, because then we don't know. Okay. So this one, it just says they're bed confined. Oh, okay. Well, remember what I told you. The Code of Federal Regulations says that bed confinement alone is not enough. We have to know more about this patient than just that they're bed confined. Now, why couldn't they go by a wheelchair? Why couldn't they do any of those things? Could they be, put into a wheelchair with assistance, and then, have a strap put around their chest to hold them in place? Just as an example. So really, this just isn't going to meet the medical necessity portion. All right. Let me get down. Oop. Then we get down into this. We have an MD signature. We know that. We have it dated. So we have what we need here. And we hit the final one. Why is this one? Well, bed confinement alone does not make it a payable transport. We know that coming from the Code of Federal Regulations. And I actually gave you the citation for that portion so that you can look at it and see what's actually happening with that. Without me or anyone else, this is where this is at. That says bed confinement alone does not make it a payable transport. And so because the only reason cited was bed confinement, it's not payable for that reason. All right. Let's go ahead and start with some question and answers. And Jennifer, I'm going to go ahead and hit the chat first, and then we'll get into the pre-submitted questions, and we'll go back to the chat. So is there anything in the chat?
There was one question, and I believe, Amanda, if this doesn't go to example 1, please put that in the chat. But she wrote, for example 1, why could that patient not go by stretcher transport? Patients that cannot ambulate into seated positions sometimes go out by stretcher. So what is the differentiating factor that requires the ambulance?
Jennifer, I might need help on this one. I know that that was an approved transport. I know that the patient themselves was the I don't know how to say it, the mass, the body mass was the differentiating factor. And I don't have all of the details on that because obviously I was just focused on the physician certification, not fully what came in with the medical record. But the body mass affected it. I don't know where to go with that, Jennifer. If you got
I
anything for
agree
me?
with you on that one, Tom. I would say the body mass might be the effector, but I will send this out to MR just to get that clarification, just to make sure we have a really good clarification for everyone. And then I'll give that answer to Tom. He can send it out.
Okay, sounds good. All right, so
And
we're going
that's
to
the
go
only
ahead and
question that's in there. Sorry.
okay, yeah. So never get. Ooh, that was not what I wanted to have happen. I'm sorry, guys. We're going to go ahead and hit the pre-submitted stuff. So what happens if the physician certification statement is inconsistent with the EMS crew findings on an assessment of the patient, such as a PCS stating the patient is bed confined, but rather EMS finds the patient sitting up or able to ambulate? Again, because a PCS can be written up to 60 days before, can a patient's condition change in that 60 days? And the answer is yes. That's why the only thing that can prove medical necessity is the assessment. So depending on what you assess during that portion coming from the EMT, that's what will prove medical necessity. Again, the PCS can help you or get to a better understanding, but it cannot prove medical necessity for the final transport. Even for the routine scheduled ambulance transport, the RAS and NAT program where we do the prior authorization, it's an affirmation, and yes, we're saying, hey, we believe this is, but we can still look at it on a claim by claim basis, and we necessarily don't do that, but other medical review entities that the federal government has can do that. All right, how is the PCS used to determine if additional mileage are medically necessary when residents request to see a specific provider that are far away? This is not a use for the PCS. The additional mileage is a separate set of regulations. And so when you're looking at that specific set, it's not going to be something that a physician certification statement would help with at all. It's not even used for that. What should the ambulance provider do when they determine that the CMN to be incorrectly filled out? Again, here we're talking the PCS. And what should you do? Well, contact the provider and have them complete a new one or go back through. Remember, you're going to make multiple contacts. So if it's a one time or it is not scheduled, so within under 24 hours one time, then you can document that it wasn't filled out correctly and you actually went back to them and you asked for clarification or you asked for additional help. It's the same thing as documenting as if you didn't get one. Okay? Now, if it is one that is for a routine schedule, you do have to go back to them, and yes, you have to have it corrected if it's completely off. I'm not sure what's off on it, so it's a little bit hard to answer that. I was asked if a medic can take this course. We do not require this, but they definitely are going to be able to. It's going to be available within the next couple of days on our YouTube channel, so we'll have that available for them. Is a PCS acceptable with minor errors? And again, this is where we went with like the date of birth, the drop-off address, etc. This is very hard for us to answer because I don't know what you consider a minor error. If you're just saying a date of birth and that date of birth is so far off that we can't even track back to the patient, that's not going to work. Now, I will tell you that this person also did mention that they were from a different state that we don't govern at all. It's not within our jurisdiction. And if your Medicare administrative contractor or MAC does not follow that and they say, no, it has to be exact, that's their right. We are not subjected to their rules and they are not subjected to our rules. What we are subjected to is what's in the Code of Federal Regulations or the CMS publications. So. Now, I do want to remind everyone again, if we're going back to what's acceptable, if I can't figure out who the patient is or one of our medical review team can't figure out who the patient is, then we can't use it. On the other hand, someone asked about a drop-off address. They were giving a main address and the drop-off address is actually a block over because the facility is that long. That's not going to affect you. That's perfectly fine. We're okay with that. So there's a couple of different situations there. Um, what steps are needed for smoother certification of transports? Look, to get the smoother certification, start with understanding when it is required. Is it routine? Is it a scheduled transport? If it's not, is it a one-time scheduled transport? Is it a one-time transport in general? Is it unscheduled? So all of those are really what's going to make it. Establish a form or establish a protocol. What do you need to be on your form? Again, I showed you one that WPS has, but it's not a mandated form. So what do you need on yours? What do you want on yours? Do you find, I'll give it an example. Do you find an office note as something that's acceptable as long as it states why it's needed? Could they simply print that? If that's the case, then yes, that may be something that works for you. So start off with those basic things. Be very clear as to what you need. Also try to get the signatures. I did get one that just said electronic requirements. Uh, I don't know where you're trying to go with this one. So yes, you can take these electronically. If you have a shared medical record, you're even allowed to put them in a shared medical record. That's perfectly fine. There is no, again, no required elements or anything like that in terms of the form that CMS needs. Now, in terms of identifying the patient, identifying the doctor, and a reason, we do need those. So if you have something that you wanted in a requirement and you send it to them and they fill it out, that's great. If you want to take a PDF version of it, whatever you want to do there, that's up to you. We do have to be able to tell if it's electronically signed on an electronic requirement, which says, it has to have a valid electronic signature. So refer back to that information. I did receive a question regarding Texas Medicaid, and it's from an Arizona provider. We are unable to answer that. We don't work with Medicaid, nor do we work with Texas, so just not within our realm. Then there was a little bit of a question that was explaining what can be charged for an emergency vehicle. And again, set back. The vehicle itself must be state registered and you must complete the Medicare enrollment. That's how we ensure that you are state registered and you have what you need. On the other hand, you must then move on to say, hey, why is it medically necessary? When our EMT did the evaluation today, it's medically necessary. In terms of physician certification statement, take that information into account. Use that to help justify. But again, 60 days, right? And can something change within 60 days? Absolutely. Could something change even within that day? Yes. So it just depends on what's going on with that patient. But remember, each ambulance transport must stand alone. So if you're saying I took them to dialysis and from dialysis, that's two transports. You can use the same physician certification statement, but you must justify within separately. Otherwise, make sure you meet the section 1861S7 of the Social Security Act. That's going to be a pretty key one there. I do want to jump back to Jennifer real quick and see if we have any more questions.
Yes, we do. So the first one says, if the PCS is dated, for example, May 26, 2026, but the transport occurred after midnight at approximately 2 a.m., will the date need to be adjusted to reflect the transport on the 27th?
No, we're okay with that. We can look at it, and by we mean like a medical person that's looking at it, not me, but like they can look at it and they can determine, oh, okay, well, yeah, we understand that it happened just after midnight, or yes, it was dated on the 26th. It's still going to be applicable. You don't have to don't get that detailed into that. On the other hand, look for 60 days. Make sure you check for 60 days. Jennifer, anything to add on that one?
No, I agree with you on that one.
Okay. Any others?
We do have a second question. Okay, can the origin and destinations be generic, like in example 2, where it says home or dialysis? Or is it better practice to have the addresses as well?
Oh, best practice is always going to be an address. But notice I said best practice. I didn't say it's required to. Best practice. Now, why is that? Well, I can give you an example. A patient's being discharged home, but they're not going to their home. So the doctor didn't realize that. So they're saying, hey, we're going to discharge them home. Well, when you go home, we can look it up and be like, that doesn't seem right. But then you find out that it really was the daughter's home or the son's home or someone else is going to take care. That's okay too. So that's why we always say best practice. Now for dialysis, it's a little bit, we're taking them for dialysis. If that physician is not coordinating the dialysis themselves, and let me give you an example. You're getting out of the hospital, you still have to go for dialysis. You now have coordination, someone, a discharge planner, someone else working with it. The physician signs it saying, yes, they have to go for dialysis. Yes, they have to go 3 times a week. But does that physician know that they are going to ABC dialysis center versus XYZ dialysis center? If not, dialysis center will work. It's just not our best practice. Okay, not the best practice, but it will work. Jennifer, anything to add on that one?
No, I 100% agree with you, Tom. I mean, it's always good to put for best practices to always put as much detail as possible, because then it doesn't make it vague and there's no questions. However, like Tom said, do you have to? Not necessarily, but it is a good practice to use as much clarification as possible to make it easier. Because remember, the reviewers can't see the actual patient. They have to look at your documentation to really paint that picture.
All right. Is there anything else?
No other questions.
All right, perfect. All right, we're gonna go ahead and go on then. So the next item I just want to talk really briefly about is our survey. You will be given the opportunity to take a survey. I'm going to have Jennifer put a link in the chat. You'll be given the opportunity when we close the event. It's going to look like this little external site box, a little continue button. If you're taking it via the Encore, you can even take it by you looking at for the picture that says online survey with the little finger at the top. Just please give us as much feedback as you can. There are 5 starting questions, and you can say yes, you want to provide more, but please take a couple of minutes to do that. CMS does look at these. We look at these. We want to see what we can actually do better with, what would be helpful, what you guys think. Okay. All right. Thanks for attending. Just a couple of things here as we close out for the end of the day. First, if you have a follow-up question, and for those of you that are on the phone, this is your instruction for sending any kind of question you have to. If you have a follow-up question, please email me. Now you're going to email WPS period GHA period education at WPSIC.com. And you're going to put ambulance transports webinar, ambulance webinar, PCS webinar, something like that, really to get the attention that it needs to come to myself or Jennifer, and we'll get you through the answers, right? Now, when you do that, again, we do take a little bit of time to get back to you. We do have 7 days to compile a list. So you won't even get it. Don't even expect an answer for at least 7 days. Like we got to get them all in, whatever. What we will do is once we get all of the answers in, we will look at them. We'll determine do you need an individual response or is this something that should go out to everyone? So you may or may not see all of those coming out. So thank you for listening. We do encourage you to provide feedback on our survey. Remember, we want the good, the bad, the ways we can improve, anything like that. Don't forget to review our live events for the most current registration that we have open. On behalf of myself, Jennifer, and all the provider outreach and education, thanks for participating today. We look forward to your survey comments. You may now disconnect.